going to be talking a little bit about proximal humeral fractures and plating for proximal humeral fractures. Over the years, I've realized that it's just a continual pendulum swing backwards and forwards between anterolateral and deltopectoral, back to anterolateral. Plating, nailing and plating, and the pendulum keeps swinging backwards and forwards. But over the years, I've come and settled on the extended anterolateral approach to the proximal humerus and using a plate. The meta-analyses are out there, 2018, published on nail versus plate, and showed no superior treatment in proximal humeral fractures. Similarly, with extended anterolateral and the deltopectoral, none of the evidence shows one is superior over the other. And you'll find on Cambridgeorthpaedics videos extolling the virtues of the deltopectoral and the virtues of the extended anterolateral in more detail. You certainly see a lot more when you do a deltopectoral approach, but in fact, you don't need to see most of this part of the humerus. And in fact, if you've got your image intensifier in a good position and good x-rays, you don't need to physically see much of the proximal humerus. When it comes to the meta-analyses of choosing your approach, whether you go anterolateral or deltopectoral, there's really no difference. This meta-analysis came out in 2019 that suggested that perhaps there's a higher incidence of AVN, avascular necrosis, in the deltopectoral approach. Here quoting AVN rates of around 5% for the deltopectoral approach. If you have a look at the plot on the top right there, you'll see that there's one paper that's skewing this forest plot all the way across to the left. And actually, if you go to that paper, it wasn't a randomized controlled trial. It was a comparative series of deltopectoral versus deltoid split, relatively small numbers, and an inordinate amount of AVN, 18%. So there's certainly something biasing this paper. One of the problems that I picked up just superficially looking at the paper was that there was a lower follow-up rate in the deltopectoral approach, in the deltoid splitting approach. And we know that if you increase your follow-up for AVN beyond 12 months to 24 months, 45 months, you'll double the incidence of AVN. And so there's certainly something here which is distorting the figures. And in fact, when they looked at outcome, there was no difference in outcome between the two groups. So take humeral head necrosis aside, all of the other features that you might be interested on and when you're choosing your approach, implant failure, infection, adverse events, non-union, impingement, really no difference. And so my disclaimer here really is I do what I do because that's what I do, and that's because not absence of evidence, there is evidence out there, but it shows that both are equally beneficial. Okay. The first tip that I'd give you, though, is don't use a plate just because you use a plate. Okay, so here we see the radiographs of a 61-year-old female enjoys playing tennis, falls, sustaining a two-part fracture of the proximal humerus. Yes, you'll see the crack lines running across the surgical neck. You'll see crack lines running into the greater tuberosity, but neither of those fracture fragments are displaced by more than a centimeter or angled by more than 45 degrees. And really all we have is this lesser tuberosity fragment in the anteriorly, which is displaced by more than a centimeter, and as such is defined as a part. So a two-part proximal humeral fracture, but of the lesser tuberosity. Here's your radiographs at 10 days, and so the greater tuberosity hasn't moved, and it hasn't moved now, it's unlikely to move. The neck fracture is in a good position, but that lesser tuberosity has displaced a little. Do we need to do anything about it? Well, it really depends on what you want. So let's have a look at the images. We see the axial images, the cracks going into greater tuberosity and across the neck, and the displaced lesser tuberosity fracture and how it's medialized and locking itself onto the front of the glenoid. I don't think the coronal and sagittal views add much when we're looking towards the lesser tuberosity, but it does add a little when I'm looking towards that head fracture. Although not displaced, it's still important. We see on the soft tissue views, the beautiful soft tissues and the beautiful rotator cuff. And this lady wanted a normal shoulder. She wasn't willing to accept that she had fractured her proximal humerus. For me, I probably wouldn't have had an operation. So what is she going to lose? And I think that's really where the volume rendering 3D CTs come in, because you can see exactly where those pieces are that have broken, not just 2 parts, 3 parts, or what those parts are, but where those parts physically are, okay, and what they might do. And so if I spin the 3D series 1 again, we see how the lesser tuberosity is locked on the front of the glenoid. And so that's going to limit her internal rotation. When she reaches behind her back to try and get into her shoulder blades or get to her bra, she'll notice struggle. But in fact, she might also struggle when she's coming up above shoulder height, when she wants to play tennis, when she comes into abduction and external rotation, because it's in that position that you then get subcoracoid impingement. Go back and have a look at the images, because there's some people who don't have a lot of room in their subcoracoid space. In fact, she's got a lot of room in her subcoracoid space, so she probably won't get too much subcoracoid impingement. But what will happen to her is when she comes into elevation, that lesser tuberosity is locked on the front of the glenoid, and as such will jam her head once it heals down onto the shaft, which it will heal in time, and will limit her elevation at an above shoulder height. And she wants a normal shoulder. So that was fixed here with headless screws, and you look at the metalwork and think, oh, that's beautiful, headless compression screws. But in fact, most of the work is being done here is being done by sutures. And so when you come to fixing the proximal humerus, even if you are plating it and want to put a plate on, you often give the shape back to the proximal humerus with sutures. Move the tuberosities round, suture the tuberosities into the right place, make sure that your head fragment is in the right sort of attitude, and then after that, put the metalwork in. So here fixed with headless screws, but there are sutures crossing the bicipital groove. And if I cross the bicipital groove, I know I'm going to tear the biceps. And if I tear the biceps, I then get an hourglass biceps. The hourglass biceps where the biceps bunches up within the shoulder and then limits your abduction to 90 degrees. She wants a normal shoulder up above shoulder height. And so when I come to my suture repair of the tuberosities, I do as little as I need, try not to cross the bicipital groove unless I really have to, and would normally use an absorbable suture. Once I've fixed the lesser tuberosity, seen beautifully reduced there on the axillary view, I then have to address the cracks across the surgical neck and cracks into the greater tuberosity. I'm also mindful of the fact now that I'm at 3 weeks. In 3 weeks, that neck fracture hasn't displaced and the greater tuberosity fragment hasn't displaced. And in fact, when you open it up, you'll find a sheet of soft tissue from the head over greater tuberosity that, although you can see it on the x-ray, that fragment's not going to migrate. And so although technically it's quite easy for me now to put a plate on, whatever approach I've used, I don't need a plate. Because we've seen from the papers from the late 90s, early 2000s on suture fixation of the proximal humerus, that relative stability often holds the pieces in enough position to allow them to heal. We read the papers of the percutaneous fixation with wires and how the union rates are low and function is good. And if I put a plate on her now, it's not going to add much to her, except cause problems when she comes into abduction and possibly some problems when she goes into active elevation. So although, you know, it's nice to use a plate when you have a plate, only use it if you need to use it. And there's her radiographs at 3 months, fracture united in a good position. The next bit of advice I have for you is to own your imaging. Here we see the sagittal coronal reconstructions, but they've been done in the plane of the scapula. And because they've been done in the plane of the scapula, because the algorithms in the x-ray department are for arthroplasty. And often when you're doing arthroplasty on the proximal, on the shoulder, it's all about the glenoid. It's about the axis of the glenoid. But here it's not about the glenoid, it's about the proximal humerus. And in fact, when we have a closer look at this fracture, although the fracture fragments aren't displaced, there is a crack running across the anatomical neck. And there's no hinge and there's no calcar. And so now I'm starting to think, this may be a little bit more than just a 2-part proximal humeral fracture with lesser tuberosity. Maybe there's a biological problem here in terms of vascularity of the head. But I'm reassured by the fact that the greater tuberosity is in continuity with the head at the back. I realize the volume rendered 3D CTs will wallpaper over some of the small cracks. And so I go back and I have a look at my sagittal views and I have a look at my axial views and I change the plane of rotation and see, yes, beautifully how greater tuberosity is actually in continuity with the head. And so although there's no calcar and there's no hinge, this is not a problem of biology. This is a pure mechanical problem of the lesser tuberosity going to jam on the front of the glenoid. For me, I wouldn't have had an operation. I do most of my work here below shoulder height when I scope people, when I operate. I play World of Tanks. I don't like tennis. But it's not what I want. It's what your patient wants or what she desires. My next tip is get an auxiliary view, and in the early days, when you're first starting out fixing a proximal humerus, try and get your auxiliary view relatively early on. We see here a proximal humerus fracture fixation done somewhere else in a 44-year-old. And when you have a closer look at the post-op CT, you'll find that they didn't quite appreciate that that humeral head was locked out the back of the glenoid. They never reduced the head in the first place. And you may wonder, how did they put this Phyllos plate on without putting the screws into the head? And that's because they worked purely on the AP radiograph. They never got an intraoperative auxiliary view. It's not that the head was reduced and then fell away, because there's no holes in that head. They never put any screws or any drill holes into that head fragment. Now, you don't always need an auxiliary view, so you can always use your fingers. So you'll find me when I'm fixing a proximal humerus, I have a finger around the back of the head to tell me where the back of the head is. I have a finger around the front of the head that tells me where the front of the head is. And I'm then visualizing that in relationship to the shaft. I've looked at my imaging, knowing that in general, the shaft will be anterior and a little bit medialized, okay? But you can still use your fingers. But what you can sometimes do then, if you're still not sure, put a couple of screws into the head, put a couple of screws into the shaft, and then get some form of axial view to make sure that your shaft is in the right place, that it's not wildly crossing the shaft, that the flexion extension attitude of your head onto your shaft is good. Doesn't have to be perfect, because you can compensate quite a lot with the proximal humerus, but make sure that it's reasonable. Own your imaging. Here we see the head fragment coming to the shaft fragment, and there's, although there is a neck fracture between the head and the tuberosities, essentially disconnecting the head from its vascular supply, there is some calcar. And all you need is 8 millimeters of calcar for that posteromedial blood supply to be able to supply the head fragment. On this occasion, it was just a case of removing the screws that were in the wrong place, reducing the head, and putting the screws in. And when you look at this auxiliary view, you'll appreciate, yes, that's why you need to own your imaging. So when you often have those valgus impacted fractures, what happens is the head goes back, but sometimes it doesn't just go into valgus, it'll be pushed backwards a little bit. And so there's a three-dimensional deformity. Here I struggled to push that head round to rotate it, because it was a few weeks down the line from the injury. But you want to bear that in mind when you're reducing your valgus impacted fracture, that it might have pushed back and down backwards a little bit. So it's not just about pushing it up, it's about pushing it round. And you see that when you look on your auxiliary view. There it is, post-op revision 2 years, not perfect placement of the screws, but as kind of defined by the plate that was there before. Thanks to that medial metaphyseal spike, the head revascularizes before it collapses and dies. Now, when I talk about owning your imaging, you don't really have to know exactly what angle your II needs to be to the shaft for the various different screws, but do set up your II so that it makes life easy for you. You can come from the top of the bed or from the far side of the bed. I prefer that technique as shown there in A, coming from the opposite side, so the image intensifier is not in my way. And then once they've come in like that, you need to bear in mind that the scapula sits at 30 degrees to the chest wall and the glenoid is at 90 degrees to the scapula. So generally you need to rock the II back away from you 30 degrees to get a nice tangential view of your glenohumeral joint. And then you need to bear in mind that the humeral head is offset retroverted 20 to 30 degrees in terms of your forearm and your transepicondylar axis. And so be aware of that, of the position of your forearm or your arm in terms of internal and external rotation when you're fixing it. So here we come with the intraoperative image. You come straight across, and that's the view that you get. You'll get a great view of the AC joint, but you don't get a good view of the glenoid. Rock the image intensifier back 30 degrees, and that will give you that beautiful on-face view of the glenoid. Think about your internal and external rotation of your humeral shaft to give you the great view of the dinosaur. When I talk about the dinosaur, it's not T-Rex, it's Diplodocus. It's about getting that shape, how the head is offset by the greater tuberosity. Okay, so you come in initially straight up and down, you rock backwards 30 degrees, you get a great view of your glenohumeral joint, and then you might internally or externally rotate it to get your screw view and your plate view. And so your screw view is when you're perfectly tangential to your screws. And you can rock your image intensifier backwards a little bit further, or you can externally rotate the arm a little bit. When you want to get your plate view, the view on the bottom right, where you see your plate, how it lines up with your head fragment and your shaft, you can deep internally rotate the arm and have a look, or rock your eye over 20 or 30 degrees until you get a good view to show you the alignment of the head to the shaft. I still think you need an axillary view. There's lots of different ways of getting it. Here we see someone doing it in the beach chair position. Can't say whether it's right or wrong. It's not the way that I would do it. But in terms of the meta-analysis evidence, there's no difference in terms of your positioning, in terms of your approach, in terms of your implant. And so you do what you do because that's what you do. So I mostly do them in beach chair position. And so for in beach chair position, to get an axillary view or tangential view of the glenoid, I will rock the eye up when I've come from the opposite side. So you see how the eye normally sits rolled back to get a view of the glenoid, and then 90 degrees to the humeral shaft. To get my axillary view, I simply bring my image intensifier straight up and down, okay? And then I rock it backwards and forwards a little bit until I get a good view of my humeral head in relationship to the glenoid. And here it's not about the glenoid, it wasn't a fracture dislocation case, but it's about that lesser tuberosity and how that is then no longer knocking on the front of the glenoid and lining up beautiful with the humeral head. If you fix your proximal humeruses, because it's a polytrauma patient, flat on their back on a radiolucent table, you don't sit them up. It's always good to think about the apical oblique in terms of thinking how you're going to position your image intensifier. This is the article from 1988 with Ian Kelly. But find a way, whatever way you set your patient up, to get a plate view, a screw view, and a axillary view. My next step when it comes to plating the proximal humerus is pick your winner and watch out for the Varus no hinge. Think about the biology of your fracture. Here, top left, horrendous proximal humerus. Greater tuberosities are blown to the side. The head has been pushed down into valgus, and it no longer looks like a proximal humerus. Bottom right, it looks more like a proximal humerus. In fact, you could almost say that was an undisplaced fracture because none of them have really displaced, well, maybe the split between the tuberosities by more than 1 centimeter. But it still looks fairly good. For me, the fracture that I'd fix or pick to have fixed as a surgeon and even as a patient would be that top left. The one I don't like is that bottom right. So let's have a look at top left, the valgus impacted proximal humeral fracture. 60-year-old. So the two tuberosities have been blown apart. The head has been pushed back. And when you have a look at it, when you have a look at that head fragment, it's not just been pushed back into valgus, but it's also been tilted a little. So bear that in mind when you come to fix it. What about the biology? We have a anatomical neck fracture separating the head from the tuberosities and from the shaft, and as such is dysvascular. But it has a really large posteromedial calcar, more than 8 millimeters. And it's that posteromedial calcar that will bring the blood back based on the posterior circumflex humeral vessels, this area here. And so there's a chance that this head will revascularize before it totally collapses, as opposed to the 63-year-old who has a Varus no hinge. The tuberosities are separated from the head, so the head is dysvascular, but there's no inferior calcar and the hinge is gone. The ice cream has fallen into the ice cream cone. And so this headpiece is totally avascular, and it'll take a long time to revascularize, which means when it starts, it's likely to collapse. Here we see that there's no calcar, there's loss of the hinge. Also, with the Varus no hinge, when the head is disconnected from that medial metaphyseal area, you then need to support that area. And that's when you need to use your kickstand screws or the bottom screws of your proximal humeral plate. Not the exact same case, but another example of a Varus no hinge, slightly more displacement. The head is rolled into Varus, the head fragment is separated from the hinge, and there's no calcar attached to the head fragment. There's the CTs, there's the volume rendered 3D CTs. And it's not totally pulled apart, but the biology in this fracture is a lot worse. And being able to support the ice cream once it's fallen into the ice cream cone is actually very difficult. You see here how there's no calcar, no hinge. Now that large fragment of articular surface on the greater tuberosity does not constitute a head split. It needs to be more than 20 or 25% of the articular surface. So she gets fixed, and a reasonable position is obtained. It's always difficult to hold the ice cream up. You may criticize the fact that the kickstand screws weren't used. It's likely that this was a extended anterolateral approach, and if you set this plate a little low to start, then the axillary nerve is always right where those kickstand screws are, but the screws are relatively low, supporting that head fragment. There's the images at 1 year with a little bit of collapse, and there's the AVN. And so this didn't happen in collapse because she didn't have kickstand screws. This happened in collapse because of the biology of this fracture. She goes on then to have an arthroplasty, which then dislocates, has a reverse, then fractures below the reverse and needs a plate. And so watch out for the biology. Pick your winners. Here we see the 60-year-old with the valgus impacted, more obvious displacement, but it's much easier to separate the tuberosities, elevate the head. Still a little bit of a problem with biology. It's not uncommon aspect of the greater tuberosity. And is that a vascular phenomenon from that blood supply coming from inferior, or is that a cracking the egg phenomenon? So when you've cracked the egg, when you've broken the greater tuberosity and you no longer load it, it then undergoes stress shielding and then resorption. So is that a vascular phenomenon or a not proper loading phenomenon? Not sure. But overall, as long as you've maintained the shape of your proximal humerus, as long as it looks a bit like a dinosaur, Diplodocus, Gerber showed us that small patchy areas of AVN in a relatively normal anatomical shaped shoulder can actually do pretty well. A 38-year-old with a 2-part fracture. Yes, there's lots of little crack lines going into the head and greater tuberosity, but they aren't displaced. This is a pure 2-part head, greater tuberosity, 1 part, and the shaft being the next part. When we look at our imaging, we'll see lots of cracks running into the tuberosities. Now, there may be some cracks running between the tuberosities. I'm a little bit nervous for the blood supply, but I see a little bit of calcar there on that sagittal view. And really here, most time for the 2-part head, surgical neck and shaft fractures, it's just about connecting that head to the shaft. It's not a biological thing. And this is where the pendulum swings backwards and forwards, left and right, nail versus plate, and the meta-analyses show no difference in outcome between nail versus plate on a number of studies, not just one. Another 2-part proximal humeral fracture, but now it's greater tuberosity. Okay, let's put greater tuberosity into Google and we'll find a classification on the morphology of the different fracture patterns. So bear in mind that they're 2-part fractures, i.e. 2-part lesser tuberosity, 2-part anatomical neck, 2-part greater tuberosity. There's 2-part surgical neck fractures where it's not about biology. And then when you even get into the nitty-gritty of the 2-part greater tuberosity fractures, there's even a further subclassification within that. And so be careful when you choose your treatment or whether to use a plate on an article that talks about a 2-part fracture. Look at the injury and think about what that needs. So if you've got lots of comminution, you've got lots of little pieces, putting a big filus plate onto it and trying to hold it with big 3.5 screws is never going to help. You might want a plate like this, which sort of fans out over the greater tuberosity. You may simply want to suture the tuberosities together, suture it back down onto the shaft, use a tension band wiring construct. And I can't say that there's one more than the other, but have a look at your fracture. Have a look at what it needs. Does it need to be just locked in with a plate? Does it need suture fixation? So let's have a look at this one. So what approach are you going to use? Well, greater tuberosity, you could come deltopectoral, you could come extended anterolateral. The blue marker is on the deltopectoral groove. The red marker is on your extended anterolateral. And let's have a look at this fracture. The nice thing about the extended anterolateral approach is it brings you right down onto the greater tuberosity and lines you up with the head fragments so that your screws and your plate and everything is sitting in the right right place. Now you could get to this fracture from the deltopectoral approach, but see how far back this greater tuberosity fragment is? It's all the way at the back here. I don't think there's much more to be learned from the axials or the sagittals. Let's have a look at the images here and see how if you came deltopectoral, you might get nice and easily to this small little comminuted fracture of the greater tuberosity. So just a single plate's not going to be enough. You're going to have to augment your fixation with sutures, anchoring this piece so it doesn't migrate proximally. And most times I'm splitting my deltoid along the anterolateral corner of the acromion, because this is where I want to get to. I want to get possibly to the front and the back. But here, this greater tuberosity fragment is right at the back. And so now, although I do what I do because that's what I do, and I do an extended anterolateral, for this one, I might actually want to split my deltoid a little bit more posterior, there where the blue mark is, as opposed to the green mark. So know your approach, know your plate, know the limitations of your approach, but don't be fixed by the dogma of that's the approach that you need to take. Here we see the phallus plate offered up to the proximal humerus and how those kickstand screws will always line up perfectly, like perfectly with your axillary nerve. And that's the danger then if you're trying to do percutaneous fixation. You don't need the kickstand screws when you're doing a two-part proximal humeral fracture of head and shaft. You'll often get enough fixation just with that proximal group of screws. But if you've got that Varus no hinge, you need to be able to get your kickstand screws in. Now you can still get them in, even with an extended anterolateral, by fixing a few screws into the proximal humerus, a few screws into the shaft, and then abducting the shoulder. Deliver the pieces that you need to see into your wound. So although that study showed us nicely how you can see most of the proximal humerus with the deltopectoral and only a certain amount of the with that, what they weren't accounting for there was how beautiful the shoulder can move and that you can deliver most of the shoulder into a relatively small hole. And if you abduct the shoulder, it detensions the axillary nerve and you can pull it to the side. Often when we read about approaches to the proximal humerus, they'll talk about the gap between the anterior and middle heads and then show you this picture. The gap between the anterior and middle heads is more anterior than you think, and it's really a physiological thing, exercising and which head you want to target. Is actually, and most times when we're talking about the middle and anterior heads, we're really splitting the deltoid around the first or second raphe. It doesn't matter which raphe you're going through, but go back to your imaging, see what's broken, see what you need to get to, see what you need to see. So most times I'll do an extended anterolateral approach. I don't like to see the axillary nerve. The studies show that there's not much difference, but I'll often leave a skin bridge because I don't need to see that nerve. I know where it is and do a split elsewhere. On this occasion, with the really posterior greater tuberosity fragment, I would have split my deltoid more posterior, not in that anterolateral corner. Most of them, if you split along that anterolateral corner, your phallus plate sits just in the right place. If your head is reduced and in the right place and your imaging is good, your screws run from your plate down into your head, heading towards your glenoid. Just makes everything so much easier. Similarly, if you're coming down this extended anterolateral approach for a four-part proximal humeral fracture, it will exit exactly where the split between your two tuberosities exits. The split between the tuberosities doesn't normally exit into bicipital groove, rotate interval. It normally leaves a little bit of greater tuberosity on attached to lesser tuberosity. And so this approach, extended anterolateral approach, brings you right down where you need to be, brings you down to where the split in the fracture is. It allows you to push your head up. It also, not just from valgus, but also support it from the back, allowing your greater tuberosity to come around. If your greater tuberosity is migrated posteriorly, you can get all the way around the back. You can put your finger around the back and the finger around the front and appreciate where your head is when you're putting your plate on. So in summary, I generally do an extended anterolateral approach when I'm plating, and most times when I fix a proximal humerus, I'll plate. I do what I do because that's what I do. I think no study shows anything is better than the other. Don't use a plate though just because you have a plate. as shown by that two-part proximal humeral fracture of the lesser tuberosity. Own your imaging. Look at your sagittals, your coronals, your axials. Volume render it so that you know exactly where it is and where you need to get to, and think about whether you might be better off with a deltopectoral, for example, that lesser tuberosity two-part proximal humeral fracture, because it was all about the stuff at the front, or whether you need to be more around the back. I think in the early days, when you are screening, think about your axillary view. Pick your winner. If you've got that Varus no hinge that's in a good position, you might want to get it done by your colleague and cancel it, get it done on somebody else's list. Know your approach and know your plate and where your plate should sit. Remember the anatomy of the axillary nerve, and if you do need to get those kickstand screws, my tip for you is then fix and then abduct, take the tension off the axillary nerve. Ignore the heads. Although we talk about the anterior and middle heads, split your deltoid where you need to be to get where you need to go. And after a while, when you've been fixing proximal humeruses, you realize that it's not just a pendulum swinging backwards and forwards. After a while, you start going round and round in circles. Thank you.